So it's the 3rd of July, and this begins the material for the next exam, exam number 4. Exam 3 grades are posted, and I've had a few people ask me, are there any extra credit assignments available? And I want to assure you that there are a number of grade boosting opportunities coming your way. Number 1, the case studies. I haven't graded the first set yet, but those should be very strong. There's a second set of case studies that I just opened up this afternoon. The syllabus doesn't say they're going to be posted until next week, but I thought, just push the buttons. So they're now available for you. I don't suspect you're going to look at those between now and the lab exam next week, but just know that they're there, and they're not due to the week before the end of the class. If your lab group has been successful, then I would just say, hey, just roll over and do the next case studies with them. And if you find yourself that through people dropping or whatever other reason, if you don't have a group or your group doesn't have 3 or 4 people in it, please let me know and I'll match make some of you into new groups. So you've got 2 case studies. Those are each worth 25 points. That's 50 points. Your lab reports are turned in. I haven't graded those, but that should also be a very strong score since we did do peer reviewing and we looked for each other's little errors. There are 2 extra credit quizzes that one is posted now, one will be coming up soon. They're on Connect. They're truly extra credit. They're open book, open resource. You should do well on those. If you don't do them, no foul. Only points in your kitty if you do them. There will be 4 of your lecture quizzes from Connect that will be dropped. So there are 14 of them altogether. Only your top 10 scores will count. That means if you have right now a couple that you missed or didn't do very well on and they're lowering your grade, that negative impact will be gone once I take those 4 lowest quiz grades away. Now that won't happen to the very, very end. And finally, there are the 30 points for doing the Connect assignments. So as long as you've been moving along and doing your Connect assignments, then there are a lot of points coming your way. We're at about 560 points or so out of the 1,000 have been assigned. Okay, but there are going to be 25, 25, 50, 80. There's over 110, 120 points coming your way that should be very, very strong based upon these extra credit or these grade boosting opportunities, okay? So hold on there. If my rule of thumb right about now is if you are sitting in the high 60s, 65 or higher, you're going to be okay. You're going to be okay. If you just continue to do what you're doing, because of these grade boosting things, you will be over that drown line of 72%. If you're below a 65 right now cumulatively, then something's got to change, right? You're not going to make it if you're 65 or lower unless there are some really significant changes about your upcoming exam grades. Talk to me if you're concerned, okay? But I can assure you that these grade altering things will make a difference of 5 to 6% on anyone's overall grade. Okay, questions on just where you are. If you're in the high 80s right now, 85 or higher, keep on doing what you're doing. Good chance you'll make an A. Right? If you're in the 75 or higher range right now, keep on doing what you're doing. Good chance you'll make a B. Okay, no guarantees on that, but if you just keep on working hard, it'll work out. I know grades right now don't look so flattering when you look at them. Okay? Questions for me? This next exam is going to be over chapters 20, 22, and 25. 20 is about blood vessels, arteries and veins, capillaries, blood pressure, things that we discussed somewhat in lab this week. Chapter 22 is over the digestive system. Not everything, but some select topics. I definitely want to talk about the liver and the pancreas for sure. And then we'll get to chapter 25, which is the respiratory system. So anyone who's going into respiratory therapy, this should be your chapter of your greatest love, because we'll be dealing with lungs and respirometry. That's also where we're heading in lab. Next week is the lab exam. That will cover the blood and cardiovascular system. Then next week after the lab exam, we'll be doing a respiratory model review of its structures. The following week, we'll be looking at respirometry, doing spirometry and vital capacity and things like that. The following week, you're in the urinary system, and then we're at the lab practical. So we've only got about, I think 4 weeks from today, we're done. 4 weeks from today, we are done. We're on our final exam 4 weeks from today. If that gives you any perspective. And in that 4 weeks, we still have 2 more lab exams and 2 more lecture exams, a case study, and a lot of quizzes. So there's a lot to do in the next month, okay? So hang in there, stay healthy, enjoy the sun, but don't get too happy. Don't stay away too much. There'll be 3 quizzes for this unit. There'll be the vessels quiz, the digestive quiz, and the respiratory quiz. So 3 more lecture quizzes coming your way, and the guided readings are on here for you as well. So let's go ahead and get started. Chapter 20. Some of this will feel like review, which is always good. Some of this will be deeper or more complete understanding of the vessels and what you have had in the past. The histology should look familiar here from lab. The layers around arteries and veins should look familiar. Blood pressure and what blood pressure is should look familiar. And toward the end of this, as you see in the cover slide, toward the end of this, name that vessel. The last 50 slides of this presentation are just, oh, that's the femoral artery, and that's the femoral vein, and oh, that's the common iliac. And I'm not going to lecture over that. That's largely review. So I'm really only going to be going through the first 114 slides or so in this chapter. After that, I'll be skipping over those last slides that talk about or just review the anatomy, the identification of the vessels. Questions? Anything at all? Okay, so we're talking about the flow of blood through the body. The flow of blood has been of intrigue for centuries, and there's a lot of history. There have been glimmers of understanding in the history. Then there have been other times where there have been misconceived ideas about the overall cardiovascular system. But it's really been since the microscope when we were able to see the capillaries and we were able to understand the circuitry of the entire system that really things came into focus. Don't worry about anybody's names, okay? Not going to ask about anybody's names. So let's start off looking at arteries versus veins. You saw this exact image in lab this week. And this is just a cross-section through a part of the body where you see a nerve, an artery, and a vein pretty prominently shown. We shouldn't have any difficulty identifying this. Is everyone okay with... over here we have what? That's the nerve. You recognize it. It's solid, if you will. If you look very closely at higher mag or even up close to the image, you can see the little myelin going around the axon. Sometimes the nerve will look like multiple nerves because it's really what you're looking at is one nerve with multiple fascicles within it. Okay? But regardless, you'll see a solid structure with little myelin circling axons. And then, when we look at this guy, that is part of the view of a artery, and we can recognize it pretty distinctly. Under the staining that you'll be seeing, you'll always see this sort of scalloped edge, okay, on the lumen. And that's going to be your telltale sign that you're looking at an artery. Yes, it is true that this has a very thick tunica media, but that's really not going to be the thing that's going to drive, your identification. It's going to be the presence of that scalloped inner border. Now that inner border is called what? What is that inner border? That would be the tunica intima, which is composed of what? The tunica intima is composed of simple squamous epithelium, which we would also call the endothelium, right? The endothelium, a special name, simple squamous. And that layer, that internal layer, is what's found in all vessels. Large, small, arteries, veins, and capillaries all have within them that very thin layer. And then what you're also noticing on this picture is this much, much larger vein. And you're seeing parts of it in there. It's flattened out. And you can't see all of it. You also can't see all of the artery. But in every view like this, you'll see the vein is always much more collapsed. We know that arteries on the bottom always carry blood away from the heart. That's an always true statement. Veins always carry blood back toward the heart. No exceptions. What connects these two vessels together, if you will, are the capillaries, and they are very, very small. They are don't think of capillaries as simply being small arteries. And I know that's sort of a common training. What we're taught is that arteries get really small until they become capillaries. Not really. Capillaries really are a distinctive, different type of vessel. They don't have 3 layers, they only have 1. So it's not fair to call capillaries small, microscopic arteries, as is sometimes done. I would not ask you to look at a picture like this. You recognize this is coming from Anatomy and Physiology Revealed. And it does highlight the different structures, the arteries, the veins, and the nerve within the image. So let's go through these layers, okay? And I think these are familiar to you. This should be largely review. So the inside layer of all vessels, arteries, veins, and capillaries, is going to be the tunica intima, aka the tunica interna. Tunic means layer, right? And this is going to be lining the lumen. This is going to be lining the inside of the blood vessel, and the other name for this is commonly the endothelium. Okay, the endothelium. It is a selectively permeable barrier, and there are some chemicals released by the endothelium. Do you recall what one of those chemicals is? Anybody remember? When we're dealing with platelets, do you recall that endothelial cells were constantly releasing a substance called prostacyclins? It was mentioned in passing. And what did that prostacyclin do? Kept the endothelium slippery, right? It didn't allow the platelets to adhere, because if platelets start to adhere, they're like rock candy, right? Once one adheres, they all start grabbing onto each other. You wouldn't want platelets to clog up your arteries and your veins. And so typically the endothelium are releasing substances that don't allow platelets to bind. But as we're going to see, there's also a number of other chemicals, not named yet, that are going to control the vasoconstriction and vasodilation of your vessels. And this will be important as we control the amount of blood flow through the arteries and veins. Oh, there it is. I got ahead of myself. So in the next one, again, there's typically substances that repel the blood cells. Again, that was the prostacyclin. And again, we don't want that to happen. But it's also true that endothelial cells, when they're damaged, invite more white blood cells to the rescue, because if the white blood cell, if the vessel's been damaged, right, there's some sort of damage, there's a potential for infection. There could be a viral agent or a pathogen, something that could be coming into your body. So wherever blood vessels get damaged, you're also going to encourage leukocytes to that area. That's going to cause swelling, right? Swelling and heat. But when those neutrophils come, right, what are they going to do? They're going to be able to fight off bacteria, or if a eosinophil was brought in, it would fight off a parasite. Okay. Now the middle layer of the vessel is going to be the tunica media. It's the middle layer. It's composed of smooth muscle. This is the layer that's going to give vessels their greatest strength. This is the layer that is going to be much stronger, much thicker in arteries. This is the layer that, if it gives out, would lead to a rupturing of a vessel, and you wouldn't want that in an artery, would you? If an artery were to rupture or to bulge out from its muscular structure, we call that an aneurysm, right? A bulging of an artery. And if that aneurysm blows, right, it can be devastating. In fact, that's what causes many strokes, right? There's a busting of a major blood vessel going to the brain, and that aneurysm leads to a lack of oxygen to a portion of the brain, and that brain damage leads to what we refer to as a stroke. There's also a constant vasomotion going through your vessels. That is, the smooth muscle of your vessels are constantly sort of rhythmically constricting and relaxing, and that's going to continue to help push blood through. So not only is the heart pumping blood under great pressure, but the vessels are also doing this little vasomotion, this little vaso dance, and that keeps blood also moving at a good pace. I should go back too and just mention that it's this muscle layer that is controlled by sympathetic and parasympathetic signals. Right, so what gives the muscles more blood during a sympathetic surge, and what restricts the blood flow to the digestive or urinary system during that same time, right? It's the amount of constriction of these smooth muscles. Lastly, the outer layer is the tunica externa. Some books will refer to it as the tunica adventitia. I'll use externa, I think, exclusively. Know that they're the same, but I don't think I'll throw the adventitia word at you. This is the outermost layer. It's mostly connective tissue. And out here you'll also find some collagen, some elastin. This is the layer that's going to connect the vessel to the body. This is the layer that's going to go up against other blood vessels, nerves, or other organs and anchor that vessel to the body. It's also within the tunica externa where one finds the vasa vasorum. From the Latin, that means vessel of the vessels. So remember that your blood vessels are cells. And I know I forget about that. I always think of blood vessels as being little garden hoses, right? And they travel through my body and they bring blood where it needs to go. But you don't want to forget that blood vessels themselves are living. The inside layer is epithelial cells, the media is muscle cells, and the outside are fibroblasts that make the collagen and the elastin. So everything about a blood vessel is living. It needs its own blood supply, and the blood going through the vessel is not what is providing energy or oxygen to the vessel. So around the outside of a blood vessel is going to be another smaller set of vessels, the vasa vasorum, and that's going to provide the nourishment for the outer layers of a blood vessel. Now, the inner layers can get some of their oxygen and some of their nutrients from the lumen itself. But if it's a bigger vessel, aorta, any of the larger vessels, there's definitely going to be a vasa vasorum in the outer layer. This is the picture you saw in lab, so I won't belabor this too much, but turning this off. There we go. So in this, we go from the larger arteries. It's called a large artery. Some books, and Saladin does it as well, calls these the elastic arteries because they do have the highest percentage of elastin in them. This allows these vessels to coil and recoil and stretch and recoil as blood is coursing through them under high pressure. Other books will call the medium-sized arteries the muscular arteries. It's not that all of them aren't muscular, right? All arteries are muscular, but they just kind of throw these words at them. So the largest arteries are called elastic. The medium-sized are oftentimes called the muscular arteries. For purposes of thinking about this, I want you imagining the elastic arteries are the great arteries leaving the heart, including what? Aorta and pulmonary trunk. The large arteries, the medium-sized arteries, we'll think of as being all the named arteries, all the other ones that we're naming on Flat Stanley. The smallest here would be the arterioles. We're not going to name any of them. They're microscopic. They're simply carrying the blood down to the capillaries. Now, when we get down to the capillaries, we're going to have just a single layer, right? Just the tunica intima. No media, no muscle layer, no externa, no large structural layer. Very delicate. All about exchange, right? Simple squamous epithelium, exchange of water, exchange of nutrients, exchange of gases, hormones. Pretty much everything that's moving out of your blood and into your tissues is going to occur at a capillary bed. Of these three, elastic arteries, muscular arteries, or arterioles, which ones do you think the body depends upon for control of where blood is going to travel or not travel at that moment? Not the layer, but do you think the body's going to depend upon constriction and vasodilation? Is it going to depend upon vasoconstriction and dilation of the great arteries, the muscle arteries, or the arterioles? Which one's going to be the greatest amount of control? Variation. Arterioles, yeah, why? I mean, it kind of makes sense when you think about it. you don't want to squeeze off your aorta and restrict blood leaving the heart, right? And likewise, you wouldn't want to be restricting the blood flow through your femoral artery very much. But down at the microscopic level of the arterioles, there's where we can really control the amount of blood moving through the body. We'll come back to that a lot, but I wanted to introduce that idea right now. Then as the blood leaves the capillary beds, then we're going to return through a series of veins, the smallest of which are called the venules, then to the medium-sized veins. Again, these are the veins on Flat Stanley we're going to be naming. These veins, many of them in the lower leg, have valves in them. That's going to keep the blood moving back in one direction. And then the largest veins, think here again, the great vessels coming back into the heart, the superior and inferior vena cava. Okay, so that's sort of the overall view of that. And again, this is a unidirectional flow away from the heart, through the arteries, through the capillaries, and back up through the veins, back to the heart. So I think I've already said everything that's on these slides. Let me just make sure, though. Arteries, again, are very strong, very resilient. They have to resist really high blood pressure. The largest ones, I use the word large. I introduce the word elastic. They're also called the conducting arteries. Again, they're conducting mass volumes of blood away from the heart. They have a lot of elastic in them, right? A lot of elastic fibers. Now here I know that there's a little bit of a discrepancy in what I just said and what's stated here. Here it's also including the carotid, the subclavian, and the common iliac arteries as being large, and they are, right? But I don't want you to worry about which one is which. Do we call the carotid a large or a medium-sized artery? I just don't want to go there. So it's all kind of a relative change as we move through the body. But just know these are the largest arteries. These are also the ones that are going to be recoiling the most, right, during pressure as the heart is pushing out blood. And these are the ones which lessen, if you will, because they do recoil, they're going to lessen the fluctuations that we see in the blood pressure. Moving along, the muscular or the medium, or in this other term, the distributing vessels, these are the ones distributing the blood to most of the body areas. Again, very, very thick layers of muscle. And then we get down to the resistance arteries, or what is also called the arterioles. And as I was mentioning here, this is where we have the greatest control when it comes to regulating blood flow to different organs. Most of that regulation comes at the level of the arterioles. Again, though, even though it's a small artery, the arterioles, there's still a very significant layer of tunica media. So always, 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 in any artery that we're discussing, the muscle layer will always be the thickest layer. Then, this little fact is new. There are little linker vessels that go from the arterioles to the capillaries. I don't think I've mentioned those in the past. And those little linker vessels are called the meta-arterioles. Okay, and it's in these meta-arterioles that one sees the precapillary sphincters. And those precapillary sphincters are little smooth muscles that are going to wrap themselves around and restrict or control, regulate the amount of blood flowing into a capillary bed. They can shut down to reduce or even almost shut off all the blood flow. Now, it can't happen forever, right? But it is possible for these capillary sphincters to squeeze down and completely shut off a capillary for a short while, right? And then open back up and restore flow through that. And again, a lot of the control of where blood flow goes in your body is dealing with these precapillary sphincters. Your body always has to make choices. All of your capillaries are not open at once, as we'll talk about when we get to blood pressure. If all of your capillaries were open at once, there would be such a massive volume that your pressure would drop. Okay, and we'll talk about that when we talk about shock in a few minutes. But your body always has to keep your vessels, some of them closed, so that the pressure can stay sufficiently high. And who was it that told us that pressure and volume were inversely related? We talked about this a little bit a while back, I believe. Maybe not. Boyle's law? What did Boyle tell us? That pressure and volume are inversely related, right? So that as pressure goes up, volume goes down. If we keep that in mind, right? If we keep Boyle in mind, that is that pressure is inversely related to volume. If we keep that in mind, that'll help us remember that we can't have all of our vessels opened at once, because that increased volume would do what? Drop the pressure. Again, APR images, I would never ask you to identify something as being a venule versus being a vein, or something being an arterial versus an artery. But when you look at this image in the center, what does jump out at you? Again, how are you going to recognize it as being an artery? Not necessarily an arterial, but an artery. What do we see here? I still see that ruffled edge on the inside, right? Still very distinctive. And, like I told you, there's a very significant layer of muscle compared to the entire structure. So again, the greatest percentage of muscle is found in the arterioles. And then when you look at the vein or the venule, it, like other veins, is more flattened and more squished. So let's figure out where those meta-arterioles are. So here's a good old artery maybe out here, and that's pretty big. And then we get into an arteriole. And then the meta-arterial is this linker. So this little linker right there where I'm going yellow, that would be the meta-arterial. Right? It's the link between the arterial and the capillary bed. And wrapped around that meta-arterial is where one sees those little precapillary sphincters, right? Those little muscles that are sitting around. Now, where are they? They're all on the proximal side of the capillary. So they're at the beginning, the entryway into the capillary bed. You don't see them over here, right? You don't see them on the venous side. So that the entryway in, and that's going to regulate, right, the blood that can go in. These are such delicate vessels that if too much pressure was going in, we'd blow it out. We also want to regulate where in our body our capillaries are open, and we also want to regulate, how much blood is going in, because this is where all the exchange happens, isn't it? This is where the water, the nutrients, the hormones, the gases, everything is happening here. So we want to regulate this as highly as possible. There is, going straight through the center, a larger vessel. Notice that the precapillary sphincters are wrapped around what? So this is the meta-arterial coming in. Can you imagine that these little precapillary sphincters could be squeezed down and blood would not be able to get out here in the capillary bed, but blood would still have to go through where? It would still go from one side to the other, wouldn't it? Would there be gas exchange in that situation? No. Okay, so it looks like red to blue, but honestly, if the meta-arterioles and the precapillary sphincters if the precapillary sphincters are shut down, you could actually have red blood going straight through, not doing gas exchange. And you'd be adding, if you would, red blood over to the venous side. So this isn't always going to happen. You're not always going to have oxygen getting dropped off at every capillary. As mentioned already, if there's a weak point in an artery or in the heart wall, that's really bad, then that bulging is going to be considered a aneurysm. Now, what's going to happen is that blood will start accumulating in the tunics, right? So as the tunica intima and the tunica media, as the media starts to bulge out, blood will start accumulating. And you would actually see a bulging, just like a bad garden hose. You would see the wall of it sort of bulging out before it blows. And typically it's a degeneration of the muscle layer. where this is going to be of greatest concern and where it's going to be most common are in the aorta, the renal arteries, and going up the carotids to the base of the brain. Now, why would those three areas be more likely to have an aneurysm? Because those three areas are also under the greatest pressure, right? Because of that constant high pressure coming off the aorta, going up the carotid, and we'll see when we get more to the urinary system, the renal arteries have quite a bit of pressure going into them for that filtering of the blood. So those are the three big areas for aneurysms, but it can be anywhere along the aorta or going up into the carotids. So here's an actual image of an aortic aneurysm, right? And you can see this bulge, right? You can see this bulge coming off from, the vessel should be like this, and you see the bulge. Now it hasn't blown yet, right? So if it's really small, sometimes they'll kind of wait and watch it. Now, I don't know that I would want to wait and watch an aneurysm if I had one, right? Because clearly it will get weaker over time. But apparently, and I don't know this story as well as I should, apparently if it's really small, it's not likely going to burst. You can use an old garden hose for quite a while, right? Before that bulge gets really big and blows. And sometimes they'll wait and watch this thing get bigger before they'll actually go in and surgically repair it. Okay, so they'll go in and repair these aneurysms if they're seen. But are there any symptoms? Do you know that you have an aneurysm? Do you know that you have a bulge? Not unless what? Pain, because it's pushing up against a nerve. So if the aneurysm was located at just the right spot where it was pushing up against something, right, that gave you a sensation that there was an issue, then you might go in. But you would not see this. You would not know what was happening. So these things, usually when someone suffers a stroke, right, it's sudden and unexpected. The aneurysm may have been there for months, but it was never known, and finally it blows.
So if they do find it, what are some ways they can, like, do they take an artery out of the leg?
I don't know, honestly, if they replace or just stitch up and reinforce. Okay, but I know they can go in and reinforce, and I'll just say it that way. How they do that, I honestly don't know all the surgical options, but they can reinforce that and minimize it.
And what causes the weakness?
High pressure, right? Over time, high pressure. But what else can weaken an artery that we learned in lab? Atherosclerosis, right? Atherosclerosis makes the vessel less elastic. And, right, what's more likely going to blow? A hose that's nice and stretchy, if you will, or one that's kind of brittle and old. Right? Your old brittle garden hose is the one that's going to blow first, not the one that has a nice stretch to it. So as long as your arteries have their elasticity, they're nice and young and healthy, good. Atherosclerosis, they get more brittle, they don't stretch as well, they're more likely to crack. Life is like a garden hose. Okay. So again, you wouldn't know it unless there was something being, that aneurysm was pushing on a structure. And if it ruptures, if it's a small rupture, right, a small hemorrhage, you might make it. But let's face it, there's so much pressure coming off the aorta that if you have a small rupture, it's like a dike opening up, right? A little opening is just going to start flooding out, and you're going to have a major, major, major hemorrhage. Now, there can be congenital weakness of vessels. Some people are just born, right? Their vessels aren't as strong. You can have, like we said already, atherosclerosis, hypertension, or be the bleeding causes. But there could be trauma to a vessel at some point. There could be bacterial infections also. And syphilis is known also to weaken the vessels. How are we going to monitor? How is the body going to internally monitor its own blood pressure? I think we know the story. I'm going to expand on it a little bit. Your vessels are very dynamic, meaning they're not static, right? They're constantly changing. Your vessels are vasoconstricting and vasodilating to accommodate your body's needs for blood and oxygen to different tissues. You've got your heart rate changing. You've got your blood pressure changing. You've got your respiration changing. Lots of things are changing. And a lot of this control, a lot of this homeostatic control is coming via your carotid sinuses. And in your carotid sinuses, you have two types of monitors, two sorts of sensors. There are both baroreceptors and chemoreceptors. As the name suggests, baroreceptors are measuring pressure. Chemoreceptors would be measuring some chemical change. We'll get to those in a moment. So baroreceptors are found in the internal carotid artery, and they're monitoring your blood pressure. And they're stretch receptors, right? They're responding to stretch and pressure. If your pressure is too high, what's going to happen? These baroreceptors will say, hey, this pressure is too high, and send a signal back to where? What regulates your heart rate? Not initiates it, right? Initiating's at the pacemaker. Well, what regulates it? Remember we had the sympathetic and the parasympathetic signals regulating your heart rate, and those signals were initiating from your medulla. So your baroreceptors are going to send a signal back to your medulla in the brainstem, and then that's going to send a signal to your heart to increase or decrease the blood pressure. So if the pressure is not sufficient at the baroreceptors, it's going to cause the heart rate to go up. If the pressure is too, what did I just say? Go the opposite. If the pressure is too low, right, it's going to cause it to increase. If it's too high, it's going to cause it to decrease. So here is a visual of where one of those baroreceptors are located. And where are we? We're right. This is what? This is the carotid. And what happens right about here? It splits into the internal and external carotid, and that's what we call the sinus, right? That space, that opening where they split. And it's right there at the beginning of the internal carotid that we have these baroreceptors. That's a great place, right? If you're going to put a monitor system up in the body to measure blood pressure, that's a good place, because you certainly want to have a good control of blood pressure going to the brain. You want to make sure there's adequate pressure, but also not too much, right? So a great place to put a receptor. Now here in the carotid bodies, or in the same area, there's also chemoreceptors. Those chemoreceptors are responding to your blood chemistry, and they're going to regulate based upon pH, CO2, and oxygen levels. Okay. Of those three molecules, pH, CO2, and O2, which of those three are the chemoreceptors actually responding to, straight up responding to? pH. So these chemoreceptors are actually responding to pH changes. Let's remind ourselves of this story. What is the normal pH of blood? Yeah. So we want a pH of 7.4. If that blood pH is what? If it is less than, so 7.4 is the average. If it's less than 7.35, we're going to say that you have acidosis, right? Your blood is too acidic. If your blood is above 7.45, we're going to say you have alkalosis, right? Too alkaline. What is it that's going to drive the pH up or down? The amount of carbon dioxide, right? So the slide tells you that the chemoreceptors are responding to pH, CO2, and oxygen, and that's true, but they're directly responding to pH changes. And what is it that's going to drive the pH up or down? Remember this, that water plus CO2 makes I'm embarrassed to say I may be off on that. Carbonic acid. It's not flowing for some reason. So that may not be right. But carbonic acid. It's an acid, right? So the more CO2 there is in your blood, the more acidic your blood will become. Do you also agree that CO2 and oxygen are going to be inversely related. So if your blood has more CO2 in it, it would have less oxygen, or vice versa. If there was more oxygen, there would be less CO2. We'll talk about that more this unit as well. So in that regard then, the chemoreceptors are measuring the pH, but pH is also a direct indication of your CO2 levels and your oxygen levels. Is that fair? That makes sense? So you have chemoreceptors and baroreceptors. They're actually regulating things differently, but for the same reason. What if your blood pH started to go down? Let's think about this. If your blood pH was going down, that means what's rising? If your blood pH is going down, that means you're becoming more acidic. You're becoming more acidic because you're accumulating what's going up? CO2. You're accumulating CO2, which also suggests that you would have what? Less oxygen. So what would your heart do in response to this? If your blood pH became more acidic, your heart would respond, and your lungs, we'll get to that in the next unit, but your heart would respond by doing what? Increasing or decreasing its rate? Increasing. Why? Because we would want to, right, pump more blood to get rid of the CO2 and to bring hopefully more oxygen in. Okay? If instead your blood pH was going up, that suggests what? That you have what? Lower CO2? Yes? High oxygen. It suggests to your brain what? Or to your heart? I've got enough oxygen right now. I don't have to pump as fast, so what would your heart rate do? Slow down. Okay? If that didn't make sense to you, go back and listen to minute 42. Now also, where else do we find these chemo and baroreceptors? We find them in the aortic, what we call the aortic bodies. That is in the aortic arch. So there are these receptors in the carotid arteries and in the aorta. Same idea, right? They're doing the same thing. There are both chemo and baroreceptors there. So this picture shows us what? Where they are, right? So there are, and this is for the aorta, so there are chemoreceptors in the aortic arch and in the going up to the carotid. I guess I should quiz this right now while we're here at this beautiful picture. What is this first branch off the aortic arch? That first branch is the what? Brachiocephalic trunk. The brachiocephalic trunk is going to do what? It's going to branch into the right common carotid and the right subclavian. The second branch off the aortic arch, left common carotid going up to the brain. Third branch, left subclavian. Any questions so far? Baroreceptors, chemoreceptors. Let's get down to the capillaries. This is where all the fun stuff is. Capillaries are the business end of the cardiovascular system. You might also call them the functional unit, because this is where really all the, I mean, yeah, the heart's the one beating. That's the pump. But as far as maintaining homeostasis and doing the business, this is where all the exchange is happening in the capillaries. Where do you not, where are some of the few places in the body where one does not see capillaries? Tendons, ligaments. Remember, those are largely avascular. That's also why they heal so poorly. Epithelia, remember, typically avascular. Thank goodness, your cornea You're not looking through blood vessels. Your cornea is avascular. And the lens of your eye also is crystal clear. So there are no blood vessels traveling through the lens. So those are really the only place where you have no or very, very few capillaries, or therefore very, very little blood flow. This story also should be a review, not from lab, but from last semester, and that is that there are 3 basic types of capillaries. This is the structural difference. And this structural difference is also going to tell you what these capillaries are primarily involved in doing. Now, the most common type of capillary in your body are the continuous capillaries. These are the capillaries all over your body. They are made up of what we've already described as having endothelial cells, simple squamous epithelium. They're tightly held together. Molecules can go through or around the cells, but with some regulation. And we'll see that there are some pericytes that wrap around the capillaries. Now, what? Peri means around, site, cells, little cells that wrap around. And they wrap around the capillaries, and they're going to have some muscle, right? And that's going to help regulate blood flow. So the capillary itself doesn't have a layer of muscle, but the capillary itself does have pericytes around it, which is going to assist in this vasoconstriction, vasodilation. That's your normal, regular, boring, typical capillary. There are 2 other kind of fancier ones, fenestrated capillaries. Fenestra, I don't think I had that in my vocab last semester, but fenestra means window. So these are fenestrated capillaries, are ones with windows or openings in them. Fenestrated capillaries are going to be found in the kidney and in the small intestine, because what's happening in these 2 locations? In the kidney, you have filtration, right? And it's through these little openings, through these little windows, through these little fenestrations that small molecules are being filtered. And there are also fenestrated capillaries in the small intestine. Again, what's going on there? Absorption of nutrients, and some of those nutrients I would describe it as kind of being a little chunky, right? And so you need sort of bigger openings into the bloodstream to allow those molecules to come in. Then there are sinusoidal or discontinuous capillaries. These are found liver, bone marrow, and spleen. These are huge gaping openings, big, irregular fenestrations. Now, why do we need discontinuous capillaries or sinusoidal capillaries in the liver? The liver is doing what? Recycling your, I should put spleen here. Yeah, spleen and liver, right? Spleen and liver are both recycling your red blood cells. And so to get those red blood cells out of the circulation, there must be openings, gaps, big discontinuous gaping holes. And for the bone marrow, why would you need discontinuous? What's happening in the bone marrow related to blood? Making all of the formed elements, red cells, white cells, and platelets. Those formed elements must enter into the bloodstream. They must have big openings to do so. So there are going to be big gaping capillaries in the bone marrow. I did not mention under fenestrated, those would also be found often around your endocrine organs. Okay, so why would you need fenestrated capillaries near your endocrine organs? Again, you need to get hormones out of the gland into the bloodstream, and there needs to be a bigger opening for that to occur oftentimes. This is a carryover idea too back from the last exam. Where are all of your blood proteins made? I shouldn't say all. Your albumins and the fibrinogen and all the clotting factors and all that stuff is made where? In the liver. So also, in addition to the recycling of red blood cells, the liver is providing the blood with some rather large molecules, right? The albumins, the fibrinogen. What does the liver not make? What protein does the liver not make in the blood? What proteins? The antibodies. Remember? So what is it we find in blood? albumins, immunoglobulins, fibrinogen, and all the other garbage pail proteins. And of all those, they're all made in the liver, except the immunoglobulins or the antibodies. They're made by some of the lymphocytes. Okay, but the liver is making all those clotting factors. And one of the questions on the exam asked, would liver damage have any effect on blood, right? And yes, it would. So within the liver, and we'll get to the structure of the liver a lot more specifically in the next chapter. I'm going to do some highlights of the digestive system and spend a little bit of time on the liver. And within the liver, well, first of all, when I say liver, what comes to mind besides a yummy meal with onions? What comes to mind? It's a yummy, it's stinky, but it's yummy. When you think about liver, you think of lots of functions, but one of the functions, what's the first thing that comes to mind? Filtering, detoxification, right? And so that means that all the blood is going to be going to the liver often. The kidneys are filtering. The liver is filtering too, but its job is to break down and get rid of toxins and other molecules that might hurt you, as well as recycle your red blood cells. So that means that within the liver, there must be a lot of what? What would you find inside? Fenestrations, clearly, for exchange of blood. There's also going to be a lot of macrophages, cells that can gobble up things that are damaged or dying. And the liver, the cells of the liver are called hepatocytes. That makes sense to us, I think. Hepato meaning liver. Lots of microvilli, because we want to increase the surface area. And not to confuse it, but we say there are a lot of sinusoids in the liver. Sinusoidal capillaries, that's one thing, but also lots of sinusoids. What's a sinus? Space, right? So sinusoids are spaces. And all the blood comes in to these sinusoids in the liver, and there it can interact with lots of macrophages and other cells that are there to kind of check and balance, looking for toxins, looking for things that it can break down. So we'll get back to that more in the next chapter. But the liver, again, very important for filtering your blood and filled with these discontinuous capillaries. I've already described a picture of this. That is, capillaries don't exist in isolation, but instead as a group or as a bed. And capillaries usually are supplied by a single meta-arteriole. Meaning what? There's a lot of control there, isn't there? So if I can restrict the flow coming off the arterial, flowing through the meta-arteriole into the capillary, and right through the middle of the capillary, what did we see a moment ago? That one straight through channel that blood could go straight through, and that's called the thoroughfare, right? It's the highway right through the middle of the capillary bed. So the meta-arteriole just kind of continues straight through, and we call that the thoroughfare channel. And again, along the way, we see precapillary sphincters. Here's a word I want to introduce, perfused. Perfused. What does that word mean to you? Have you heard that word before? Perfused. Do you have good perfusion? Perfusion is the amount of blood going to your organ or to an organ. The brain must be highly perfused, right? There must be a very significant amount of blood flow going to the brain. Other organs require less blood flow. But regardless, you need to have good perfusion of your organs. And that control comes at the capillaries, doesn't it? So if we have good capillary flow, we would have good perfusion. When capillaries are open, then tissues will be well perfused, right? Lots of blood, lots of oxygen, lots of gas exchange going on, lots of nutrients. When the sphincters are closed, then there isn't blood going through the capillaries, and that tissue at that moment would not be well perfused, would it? But here's the kicker. At any one moment, 3/4 of all of your capillaries are shut down. Or 1/4 are open. So again, the body's making choices, isn't it? It has to, we only have 5 or so liters of blood, and that 5 liters of blood needs to be distributed to where it needs to be. We need to maintain our blood pressure so that we can get the blood to its points. And if we opened up all the capillaries at once, then the amount of volume, the amount of space would be so great. What would happen to our blood pressure? Remember, pressure and volume inversely related. So if all the capillaries opened up at once, the volume would be so tremendously large that the pressure would drop. So we can't let that happen. Now we'll talk about a couple situations where that does happen, and that's not a good thing. So here's that same picture, I believe, of a capillary bed. Again, we've got the thoroughfare channel going straight through. What is the thoroughfare channel? Well, it's the meta-arteriole that then continues. Again, if we can open this up, if those little meta-arteriole, if those little precapillary sphincters are open, that means that blood is going through all the capillaries, the tissue is well perfused, gases are being exchanged, nutrients are being delivered, waste products are being picked up. If those little precapillary sphincters are closed down, then all these capillaries are not getting blood, and the blood is going straight through the capillary bed. So, better here, right? So, when we say the capillary is closed, it's referring to blood going straight through the thoroughfare channel and no blood going into the capillary beds. Now, this is sort of what's happening at your skeletal muscles when they're resting. Right? Do your skeletal muscles need a lot of blood flow all the time?
No.
When you're resting, or rest and digest, right, during parasympathetic moments, your digestive system, your urinary system is getting more blood. Your skeletal muscle is getting less. Under sympathetic, right, your blood vessels are going to bring more blood to your muscles. So again, that kind of control that we see with sympathetic and parasympathetic, a lot of it has to do with these precapillary sphincters. Okay, so we've gotten through the capillary bed. Now let's get to our veins. The veins have the greatest capacity for storing blood. They have the largest lumen, right? Lumen in an artery is small. A lumen in a vein is much, much larger. Their walls, as we know, are very flaccid, not very much muscle, not very much elastic tissue. They tend to collapse when they're empty. They also can expand very easily because they don't have any way of resisting that, and that would be called a varicose vein. Right? So a varicose vein is an expanded vein that is sort of, widening up and becomes a lovely mark on our leg, right? Varicose vein. Veins, as we know, as they're coming back toward the heart, are merging with each other to become bigger and bigger and bigger. That was the opposite of the arteries. As the arteries move away from the heart, they're getting smaller and smaller and smaller. Very little blood pressure. Very little blood pressure at all coming through the veins. So if you look at your blood at any one moment, right, over half of your blood is sitting in your veins, just at rest. A little bit in your arteries, 11%, 5% in your capillaries. Your pulmonary circuit, about 18%, and your heart taking up about 12%. Don't memorize those numbers, just appreciate that at rest, the vast majority of your blood, over half of it, is sitting in your veins. The smallest veins of all are those little post-capillary venules, the little tiny venules at the end of the capillaries. And what we're going to see is that those little post-capillary venules are very, very porous. Meaning what? They're leaky. Right? They allow molecules in and out very easily. And we'll come back and talk about how blood cells and water and nutrients are moving around in the capillaries. We then come up to the medium size, the muscular, the next larger, the regular venules. And there's not a lot of muscle on them, right? They don't have a lot of muscle. there's not much to them at all. Look at their sizes, up to 1 millimeter in diameter. About as thick as your fingernail, right? Then you get up to your medium veins. Don't memorize the numbers, but 10 millimeters in diameter. These oftentimes have the valves, and these are the ones that can start to fill up with blood and create varicose veins. Another reason for varicose veins are faulty valves. So if the valves start to form, if the valves start to not do their job, that means that blood would do what? If the valves in your legs start to fail and blood is no longer kept at its place of elevation, that means that more blood will continue to fall back down and pool. That's going to stretch those veins and become lovely spider veins and varicose veins. Is mentioned in lab, some of the force that pushes blood back through the veins is the skeletal muscle pump, the pumping of your muscles of your body. Again, there's very little muscle around veins. So that means that there isn't what? There isn't the chance of veins to do what? Vasoconstrict or vasodilate. They're just kind of these floppy, empty, weak vessels. So they don't have much choice but to just fill and expand, and they don't have much ability to push. The word I was looking for there is that veins are not capable of vasomotion, right? They're not able of changing the muscle movement. Now the larger veins, there's a little bit of muscle, but not much. Again, very thin. And this is going to be those, when I think of large veins, I'm thinking of the vena cava. This also, though, includes the pulmonary veins and the jugulars. So varicose veins, like I've already said, are more common in people who are standing around a lot, who don't get as much blood flow through their legs. When you're standing still, when you're a cashier, right, and you're standing on your feet for 6, 7, 8 hours a day and you're not moving around very much, you're not using your leg muscles very much, and so you're not using your skeletal muscle pump. The valves are having to work more, right? They're having to work harder because there isn't as much help from the skeletal muscles to push that blood. And so those individuals are going to have more valve issues over time and would have more varicose veins as a result. There's also just good old heredity. I mean, if grandma's got a lot of varicose veins, you might have more just because of some weakness that's hereditary. And obesity certainly also contributes to it, as do pregnancy. Hemorrhoids are really just varicose veins of the anal canal. There's a lovely thought, right? But increased blood flow to the veins of the anal area will lead to that, again, that swelling that can be painful. Any questions just about, in general, arteries, capillaries, veins, structurally, purpose, anatomy, anything at all?
When the capillary beds are closed for periods of time, how does that affect the cells?
Okay, so the question is, what happens to the cells when the capillaries are closed? I told you that at any one moment, 3/4 of your capillaries are shut down, but they're not shut down for long. It's like the body just taking turns. Okay, so there's just never all of them open, but they're taking turns. Some open more than others based upon the needs of the body and that organ at that time. But we can never shut them down for a long time, right? Because now the cells in the neighboring area aren't getting their oxygen, and all cells need a constant supply. So we're not talking about shutting like permanent, like 6 hours later I'll open up. We're talking about just this constant exchange, vasomotion, opening and closing. Okay, but at any one moment, snapshot, 3/4 are closed. Let's take a break there. I feel us fading just a little bit. And regenerate, 5, 6 minutes, get a little water. Let's get the skeletal muscle pump working. Okay, so we've been through arteries and veins and capillaries. How do these things all go together? So let's look at a few different circulation routes. So the simplest, right, when you think about circulation throughout your entire body, We just think about this basic idea from heart, out the arteries, down to the arterioles, through the capillaries, back to the venules, the veins, and back to the heart, right? So that's the basic pathway that we think about, and that's what's shown here in number 1, at the very top of this image. That's what's most common. In doing so, the blood is only passing through one network of capillaries and returns. Okay, so that's the first and most common route in our body. However, there are also what are called portal systems. And in portal systems, blood is going through 2 different capillary beds back to back before coming back to the heart. Now, one of these you know about. You know where there's a double capillary bed. We talked about it last semester. That is in the kidney. Remember, there was the glomerulus, which is a ball of a capillary bed. And then after that, there were the peritubular or the vasa recta, another capillary bed. So in the kidney, you've seen this idea of a portal system where we go through one capillary bed and then another capillary bed. This is also, though, the route that is seen in your intestines. When you absorb nutrients into your small intestine, right, what happens? I mean, where does that absorption happen? I'm telling you, absorption of nutrients happen at capillaries, right? So there's a capillary bed where you picked up the nutrients, but then where do those nutrients go? First, in your body, to the liver, where they will be detoxified and checked out. And in the liver, it's also another capillary bed. So we go through a second capillary bed as we absorb nutrients into our body through the intestines and onto the liver for detoxifying. And also, between the hypothalamus and the anterior pituitary. What's going on there? Hypothalamus down to the anterior pituitary, there are a direct blood flow that goes from the hypothalamus down, and we discussed that briefly in the endocrine system. So that's a portal system. Then there are anastomoses. Anastomoses are where 2 blood vessels merge together. So we see that here, this anastomosis, where one vessel is splits and then it merges back, right? So it's doing that. And what that's going to do is, in this scenario, the artery is able to flow directly into the vein. See how it goes around? And completely bypasses the capillary. We might call that a shunt, right? So a shunt is where blood is shunted, moved directly around the capillary from the red side to the blue side. And then finally, there are more substantial anastomoses. This is a venous anastomosis. This is the most common type of anastomosis. And this is where one vein empties directly into another one. And so you get this down here in the bottom left. That's a venous anastomosis. So if you had a blockage here in this vein, what would your blood do? It would just go another route, right? No big deal. No foul, no loss. Nothing happens. So if you block a vein, it's not that big a deal because there's always another way to get the blood back. Are the veins doing anything? I mean, are they delivering anything? Are they bringing oxygen? Are they bringing nutrients? Are they bringing water? Are they bringing hormones? All they're really doing is returning the blood back to the heart to once again be circulated. So if you block off a venous side, it's okay. You can take a vein out of your body. You can strip the veins out of your leg. You can take veins out and use them for surgical correction of other areas. And in the end, blood will still get back to the heart regardless. Okay. There's also arterial anastomoses. These are more rare, where 2 arteries merge. And this is true when you're going up to the heart. Up to the brain. There are alternative routes. So we won't mention it too much, but as blood goes up the right carotid artery, there is the opportunity for blood going up the left side to perfuse the brain. So if you had some restriction of blood up one side of the neck, you would be able to make up for it in part by blood going up the other side. So again, this idea that 2 arteries are going to one organ And that's, again, basically another protective mechanism. So you could have a minor blockage and still have normal blood flow, and you wouldn't know about it. This is also true around the heart. Your coronary circulation, a small blockage in a coronary artery, there's sometimes, not always, but sometimes there's a way of getting around it, so you wouldn't be aware of it. It wouldn't cause any substantial damage. So those are the circulation routes. Okay, most common, what we think about, but then there's portal systems, shunts, and anastomoses. That brings us to a little bit of a, quote, I'm going to call it a physics lesson, but we got to think about numbers here just a little bit and about how blood flows. But this will make sense, I think, and pull this whole story together, why we've been talking about all this. So, what allows any fluid to move through a vessel? What did I say before? Pressure, right? There has to be a change in pressure. There has to be more pressure at the front, pushing that fluid, that blood, through that vessel. And what's always fighting against that flow is going to be resistance. What was the other word we used for resistance when it came to the heart? What was the very last chapter, before we had the exam, I mentioned the idea of afterload. Afterload really was, quote, resistance, how much more difficult it was for the heart to push blood out. So we have blood flow. That's going to be measured in liters per minute or milliliters per minute. And then there's perfusion. Again, now look at the units here. The amount of blood per minute per gram. So perfusion is not only the amount of blood going to a tissue, mils per minute, but also is related to how big the tissue is. So a large organ, right, would need more blood than a small organ to maintain its perfusion. Now, at rest, your total flow of blood is rather constant. That's good old homeostasis kicking in. And your cardiac output, we're going to give an average of 5¼ liters per minute. Again, how much blood do you have? About 5¼ liters. So again, the idea about every drop of your blood is being pushed around every minute. Okay? So cardiac output. Now remember, what is cardiac output? Stroke volume times heart rate. You need to know that equation. Know it for this exam, know it for the lab exam next week as well. Why do we need to make sure we have adequate blood flow? And why do we have to make sure we have adequate perfusion? Because we have to make sure that we have adequate nutrients and oxygen delivered and plenty of opportunity for the waste products to be removed. This whole process of measuring blood flow is the science of hemodynamics. Hemo, blood, dynamic, something that is moving, right? So hemodynamics, the study of blood flow, blood pressure, and resistance. Here's the equation, the relationship, I should say. F, flow, is, what's this sign? Proportional to the change in pressure, delta, triangle is delta, delta P means the change or the difference in the pressure, divided by, or how is it negatively influenced by the resistance. So we've already said flow we know is related to the pressure and is divided by or inversely related to the resistance. The greater the pressure difference, the greater the flow. Does that make sense? Right, if I turn my water on really high with a lot of pressure, I'll get more flow. And the greater the resistance, the reduction in the flow, right? The less flow. So we're going to be moving into this idea of hemodynamics and blood flow and blood pressure. So we talked about blood pressure in lab a little bit. We know it's the pressure. It's a measurement of the pressure on the inside wall of your arteries. We're going to measure it using a sphygmomanometer. We're typically going to measure it at the brachial artery for two reasons, right? One, I don't want to squeeze off my aorta. It's hard to get to. Number two, I wouldn't want to squeeze around my carotids, right? That'd be cutting off blood to the brain. So cutting off blood flow to the fingers for a moment is okay. When we're doing blood pressure, we're going to take the systolic and the diastolic pressure, that is the pressure on the vessels at the time of contraction. And also we're going to get a diastolic volume, or sorry, a diastolic pressure, the pressure on the vessels at rest. Here I'm saying 120 over 75. In lab I said 120 over 80. Anywhere in that range, right, it would be a normal blood pressure. Now here's a concept I want you to listen to. This is a new thing, I think, for all of you. And that is this thing called pulse pressure. It's very, very simple. And that is, it's the difference between your systolic and your diastolic pressure. So, if my pressure is 120 over 80, what is my pulse pressure? 40, right? Subtract the 2, right? So it's that easy. So the difference in the systolic and diastolic equals your pulse pressure, and that would be 40 in this situation of 120 over 80. Think about your blood. What's it doing? Pulsing, right? When you measure your pulse, what are you feeling? Let's make sense of this term, pulse pressure. When you take your pulse, what are you feeling? The expansion and recoiling of your arteries. Would you feel a pulse if there was a very low pulse pressure?
Be weak.
For example, wouldn't happen, but if you had a pressure of 110 over 100, or 100, what's your pulse pressure? 10. Not much pulse to feel, is there? So there's not much difference. So you wouldn't feel that expansion and recoiling. All right, so pulse pressure, the pressure necessary to take your pulse. Another way of thinking about it. Now, another term here I want you to know is your mean arterial pressure, your MAP. If I say to you, what is your blood pressure, you might tell me 120 over 80. But even more important would be, what is your mean arterial pressure? And this is how you do that. You would take your diastolic pressure and add 1/3 of your pulse pressure. Okay? So diastolic pressure plus 1/3 of your pulse pressure. What is this measuring? It's actually measuring your average blood pressure across all time, right? The average blood pressure all the time. What did we learn last chapter? That the heart spends about half its time in total diastole, in total rest. It's spending a lot less time in true systole, right, in contraction phase. So if I wanted to look at what is the average, the mean pressure on the arteries over a long period of time, I would use this equation. Diastolic plus 1/3 of the pulse pressure. So this is going to tell you, when you look at your MAP, it's going to tell you what is your risk level for edema, swelling, for fainting, for atherosclerosis, kidney failure, aneurysm. There's a lot that we can tell here. So what would be, if your pressure given is 120 over 80, what's your MAP? Diastolic, right? MAP equals diastolic 80 plus 1/3 of 40. So 1/3 of 40 is roughly 13. So we would say that it's around 93. So what is that saying? That at the average pressure on your arteries, when you consider the time in contraction and the time in rest, would be 93. And the units here would be millimeters of mercury, right? The same unit we have for blood pressure. Hypertension, anything over 140 over 90, either number. Hypertension leads to a weakening of your arteries, and again, that horrible thing, aneurysms, right? The higher the pressure, the more likely they're going to bulge and burst. Hypotension can be a problem. Too low of a blood pressure. Well, if your blood pressure is not high enough, your tissues may not be adequately perfused, which could lead to, if we're talking about the brain, right, Oh, my brain's not getting enough oxygen. That's not good. Or your kidneys aren't getting enough blood to filter. And I'll tell you again, when we get to the kidneys get really pissed off when they don't have enough blood. So when the blood pressure goes too low, they shut down. They just say, forget this. So low blood pressure can cause kidney problems because they kind of shut down. So what would cause hypotension? Blood loss. Too low of blood, right? You're bleeding out, you're hemorrhaging. If you're bleeding out, your blood pressure is going to go down. Dehydration. Yeah? Not enough water. What's going to decrease? Low water, lower plasma levels, lower blood volume. Lower blood volume equals lower blood pressure. And anemia, low levels of red blood cells, right? Which also could decrease the blood pressure. So we need to have blood pressure because we need to have adequate force to get blood to where it's going. Right? We got to get blood to your brain. We have to get blood down to your big toe. We have to get blood going to your kidneys. It's sufficient pressure to get the filtration job done. As we've already said, the vessels must be able to stretch and recoil to withstand this high pressure. And boy, is that ever important, right? Because if your vessels can no longer stretch and recoil and they start getting brittle, crunchy, right, then they're more prone to atherosclerosis. They're less able to withstand that pressure coming off the aorta, and we're going to start having some really significant cardiovascular problems. We've said this, blood pressure will rise with age, right? Definitely go up with age. And why? The arteries become less distensible. Another way of thinking about it, they become less elastic. Therefore, they can absorb less of that force. If the arteries are becoming less distensible, then what's happening to our afterload? If the vessels can't stretch, therefore they're going to be more constricted. That's going to increase the resistance, isn't it? So the afterload is going to go up. So if the afterload goes up, what does increased afterload do? Decreases stroke volume. Right? And that's why blood pressure, right? That's one of the things we've been talking about in lab. So if your stroke volume is going down, what is going to increase? Heart rate. The idea, though, is that the body's going to try to keep that cardiac output the same. So as afterload increases, as the crud of our vessels starts to accumulate, atherosclerosis, as our vessels become less stretchy and less distensible and more resistant to blood flow, then the stroke volume will go down. Heart rate will have to increase to compensate. Okay, and that's exactly what we've been talking about in lab. Now, what's going to cause resistance? Let's think about this. What was our equation? Flow is proportional to the change in pressure over resistance. That is, as resistance increases, flow goes down, right? As resistance increases, blood flow will go down. What's going to influence? What factors are going to influence the resistance? Well, one is going to be blood viscosity, how thick your blood is. Is that something that changes every day? Does that change a lot? No, right? It's really, yes, blood viscosity can be an issue, right? You can be polycythemic, you can have a higher number of red blood cells, that can lead to thicker blood, but it's not something that's constantly changing all the time. Vessel length. Your cardiovascular system is a closed system. Yes, you can make new vessels, you can increase the length and have angiogenesis, making of new vessels, but this is not something that is changing drastically moment by moment. So the only thing that's really changing drastically moment by moment is the radius of your vessels. Now the radius of your vessels, what's controlling the radius? right? Smooth muscle around all of your arteries. Vasoconstriction, vasodilation, those changes are always occurring. And that's going to have the greatest effect on the resistance and therefore the greatest effect on overall flow. I'll come back to that quite a bit. You saw an image almost like this, exactly like this in lab this week. And that is, and I don't think you had it in your PowerPoints, and some of you are upset with me, so I apologize. Now you've got it, here it is. So this image where you've got at the aorta, what do we have? At the aorta, average, about 120 over 80, right, pressure. What's the pulse pressure there? Yep, the pulse pressure there would be 40. As we go away down to the arteries, let's say the larger arteries and the smaller arteries, we're talking about like the brachial artery, you're still getting a representation of your aorta. It's not exactly the same as the pressure at your aorta, but it's a pretty good indication. Pulse pressure is getting smaller, isn't it? Now, by the time I get down to the arterioles and enter into the capillaries right here, my pulse pressure is basically what? 0, right? Because there's no difference in the systolic and the diastolic. There's no pulse. That means that blood is going into your capillaries as sort of a steady or a steady stream. We can regulate it through those meta-arterioles. We can regulate it through those precapillary sphincters, but the pressure is rather constant. As we go through the capillaries, it drops even lower to about 20, and then we see that it comes back and approaches 0, the overall pressure in the vena cava. So I just said to you that resistance is going to oppose flow. We got that from the equation, right? Resistance is in the denominator. And I told you that there are 3 things that can change your resistance, one being the viscosity or the thickness of your blood. And yes, it can change, but it's not a major player. You can have increased viscosity with polycythemia. You can have increased viscosity with dehydration. Absolutely. But it's not something that's going to fluctuate with tremendous effects. You can also have, let's figure this one out. Why would albumin, I think we got this one figured out, right? More red blood cells, polycythemia would lead to thicker blood. We're okay with that one. What is it about albumin? What does albumin do? It's a protein, most abundant protein in your plasma. Solutes suck. So albumin, if it's deficient, would do what? Not as many proteins in the blood, therefore not as much water being drawn into the blood, therefore overall blood pressure would drop. Why would one have lower albumin? Liver damage, right? Because remember, albumin is made in the liver. So if you had liver disease, liver damage, then you would have less albumins. Less albumins would give you less proteins, less solute in your blood, and would lead to a change in volume, and therefore also a change in thickness, okay? Now the second thing I mentioned already is the length of your blood vessels, but again, that's fairly constant. It doesn't change constantly. What I told you is that the biggest predictor, the most powerful influence over your flow through your vessels is going to be from the radius of the vessels, right? That vasomotion, that constriction and dilation caused by your smooth muscles. Now, the mathematical relationship here for vessel is that flow is proportional to the 4th power of the radius. Okay, flow is proportional to the 4th power of the radius. So let's look at this problem. If at rest, the radius of a vessel is 3 millimeters, and then A moment later, it vasoconstricts, and now the radius of that vessel is only 1 millimeter. I think I just said this backwards from my words, but regardless, there's a change from 3 millimeters to 1 millimeter, either by constriction or dilation. It's only, what? Changing from 1 to 3 millimeters. Big deal, right? But the flow will be influenced by the fourth power of that. So a threefold increase or decrease in the radius of the vessel will result in an 81-fold change in the flow. Where is that coming from? Okay, so 3 to the fourth power is 81. Okay. What if it was from 1 to 2? If I went from 1 millimeter to 2 millimeters? What's the difference there? Right? So the fold increase, it doubled, right? And 2 to the 4 is 16. So just changing the diameter of the vessel, which is happening all the time, right? Vasoconstriction, vasodilation, vasomotion has huge impact on the flow differences to or through your blood. So again, viscosity, it's minor. Length of vessels, minor. Radius, diameter, huge. And this is constantly being changed. So looking at this as a cartoon representation, right, the arrows represent the amount of flow. So a bigger vessel certainly has more flow, but it's at the difference in flow is related to the radius to the fourth power. So what happens to blood as it goes from your aorta to your capillaries? Does the blood slow down or does the blood speed up? What do you think? Is it going to speed up or slow down? I'm hearing speed up, and maybe you're thinking that because the vessels are getting smaller and smaller and smaller. And when you squeeze on a garden hose and it gets smaller, right, it causes the pressure to increase. But don't forget that as blood is leaving the aorta, it splits into 2, 4, 8. I mean, the number of vessels is increasing, isn't it? And so the amount of area, volume is increasing. So what would happen to the pressure? It drops. And we saw that a moment ago in the picture, right? As we go away from the heart, the pressure goes down. So it turns out that with greater distance, as the blood is spreading throughout parts of your body, there's an increase in the friction, there's an increase in the amount of resistance, and that's going to slow everything down. Okay? Another way of thinking about it, the further we go away from the heart, the greater the total area is for all the vessels. If you took the collective area of all of your capillaries, that's huge compared to the area of your aorta. Okay, so as the volume goes up of all the vessels, the pressure is going to go down. Thank you, Mr. Boyle. Now, what's going to happen as we go from the capillaries back to the large veins? Again, the capillaries have a huge amount of area. The veins are getting large, they're merging together, larger and larger and larger, so the inverse is going to happen. Flow will once again increase. And as you're going from small to larger vessels, the amount of resistance would be decreasing as we come back toward the heart. Okay? It'll get faster as it comes back to the vena cava, but it will not ever be as fast as it was leaving the heart. So it's not a complete return to speed. Okay, so we leave under high pressure, high speed. We start to slow down as we go through all the smaller arteries into the capillaries. We pick it back up as we come back around to the veins, but we never recover to the speed that we left the heart in. I think we got this idea at the very beginning. That is, the greatest amount of control over the blood flow through your body is at the arterioles. Why? Because they've got a lot of muscle, and we also can control the amount of blood going in and out of capillaries by influencing the arterial flow. So over half, right? Half or more of all of your resistance is coming from changes in the arterioles. Again, there are also more arterioles, aren't there? So there's a greater number of them. This also gives us greater control over the whole situation. What's vasomotion again? Constant constriction and dilation of the vessels in a rhythmic way, right? Vasomotion. So, do you recognize right now that vasomotion is the most important thing for changing blood flow? Right? It's not the radius. Sorry, it is the radius, right? That's so important. It's not the viscosity. It's not the length of the vessels. So there are 3 ways that your body's going to control vasomotion. This is so cool. This is good stuff. So the ways that your vessels are going to control opening and closing: local, neural, and hormonal. So let me go through each of those. Local control would also be considered autoregulation. And also, if you go back and look at these titles, it looks like local control doesn't include the nervous system and doesn't include hormones. Right? So local control is also autoregulatory. And we're going to see that your vessels just do this. Your tissues can regulate their own blood supply. Well, let's think sort of teleological for a moment. If your liver and you're not getting enough blood flow, you would want to be able to control your own destiny, right? To control your own blood flow. So the theory is this: if, and it's true, if you're not getting enough oxygen, enough blood flow to your tissue, what's happening in that local environment? We've already talked about this. If you aren't getting enough oxygen, oxygen is down, then that means that your CO2 would be increasing. You're not getting enough fresh oxygen. You're not getting rid of your CO2. As a result, your blood pH is going to go down. Yes, more CO2, more acid, lower pH. That's exactly what's happening. And that drop in pH is what's going to drive this autoregulation. Okay, it says waste products are accumulating. The big waste product here would be CO2. If this were muscle, what else? What other metabolic waste is accumulating? Right? Lactic acid would also be accumulating, and you would drive your pH down. So it turns out that when your tissues are not getting enough oxygen, not only is there a pH change, but platelets and endothelial cells can begin to stimulate vasomotion. They start releasing histamine. Histamines. What do? Vasodilator, right? Increase the blood flow. So what are we saying? There isn't enough oxygen, right? There's a constriction of blood flow. So what's the body going to do? Release some histamines at the local area, not the whole body, just the tissues in that local area are going to start releasing histamines. That's a vasodilator, opens it up. Bradykinin also does that. Prostaglandins also. All of these stimulate vasodilation. Also, the endothelial cells start secreting prostacyclin and nitric oxide. Again, those are all vasodilators. So it's interesting that all of these molecules come and help to open up and increase vasomotion, increase the blood flow. So again, this is at the local control. What would hyperemia be? too much blood flow, right? So once you have a restriction and then your cells start releasing histamines and start releasing nitric oxide and start releasing these vasodilators, what happens? The blood flow will be, for a while, increased. So in reaction to the restriction, you would then have hyperemia, right, an increase in blood flow. And what's that going to do? Restore the blood flow. So your tissues have this ability of controlling their own blood flow at the local environment. It's also possible to increase, if there isn't enough blood flow, it's also possible to increase angiogenesis. We know angiogenesis, right? The word means to make more blood vessels. If I have more blood vessels, I have more oxygen coming in. So this is what happens every month in the uterus in menstruating women. This is what's happening in the heart. If you have a small coronary obstruction, a small one that went unnoticed, your heart is actually going to cause more blood vessels to be formed to help make up for that restriction. Also, if you're exercising well, your muscles are going to be getting more blood flow through increased angiogenesis, and unfortunately, malignant tumors also are able to upregulate their angiogenesis. So that's what's happening at the local control. No nervous system's involved, no hormones are involved. That would be the first line of defense, right? If there isn't enough flow, we're going to increase our vasodilators. Now, nervous system, now we're thinking back to sympathetic, right? The sympathetic nervous system. And we know that during sympathetic nervous system, what happens? When there's a sympathetic surge, there's going to be an increase in blood flow to some organs and a decrease of blood flow in others. So it's going to cause most vessels to constrict. Not all. Right? Some vessels are actually going to dilate. Which ones? The ones going to your muscles, the one going to your heart, right? If you're going to fight or flight, if you're going to fight off the bear, you better have more blood flow going to your muscles, you better have more blood going to your heart, right? So you can flee. But the rest of your body kind of gets robbed, doesn't it, during that moment? There's less blood flow going to your GI system, to your kidneys. Also, what else is influencing this from the nervous system? We've already talked about the baroreceptors and the chemoreceptors. There's one more, though, that's involved, and that is this. The medullary ischemic reflex. Talk to me. Where do you think that is? Medullary sounds a lot like the medulla. Ischemic, not getting enough oxygen. The medullary ischemic reflex is based upon changes in your cerebral spinal fluid. The baroreflectors and the chemoreflexes were based upon changes in your blood, weren't they? Right? Pressure and chemical changes in your blood. There's also, though, the medulla is measuring the pH of the cerebral spinal fluid. And that also is going to kick up, right? So if that becomes more acidic, if your CSF becomes more acidic, the medullary reflex will kick in, and that will also increase your blood flow to the brain. Now, there's a couple more facts about this. We know about the baroreflex already. What you don't know, I don't believe, is which nerve's involved. The baroreflexes are involving your glossopharyngeal nerve. You know that is cranial nerve number what? 9, right? IX. Okay? So what if what if you have an increase in blood pressure? Increase in blood pressure? Glossopharyngeal nerve senses it, or I should say, the baroreceptors sense it, send the signal through the glossopharyngeal nerve Where's that nerve going? Back to, where do the cranial nerves come from, guys? Craniosacral, right? Do you remember what are the four nerves, the four cranial nerves involved with the parasympathetic nervous system?
7, 9,
3, 7, 9, 10. Okay? So the glossopharyngeal nerve is definitely involved with your blood pressure. And what it's going to do, if your blood pressure is too high, what's your body want to do? Decrease. It's going to send a signal to your medulla. It's going to inhibit your cardiac center. It's going to slow down, right, or reduce the sympathetic tone. If we're going to reduce the sympathetic tone, what are we going to excite? We're going to excite the parasympathetic signal. And the parasympathetic signal, remember, was being sent by the vagus nerve, number 10. As a result, we're going to reduce the blood pressure, aren't we? I think we know the story, right? If the blood pressure is too high, then we're going to reduce the blood pressure. What's new here is the glossopharyngeal nerve is involved. Now, this is something that we can deal with in a short term. Your baroreceptors are very important for adjusting your blood pressure, for example, when you get out of bed or when you get up off the chair. Do you agree that the moment you get out of bed, the moment you sit up out of a chair, there is a pretty drastic change in the blood flow through your body? That drop in blood pressure could, if not well regulated, cause you to faint, right? That immediate change of position. Now, what happens to people who get older? They lose the ability to regulate this quickly, and when they stand up, they feel faint. So in a normal, healthy person, and when all of these systems are working well, we stand up, and even though there was a drop in blood pressure, our baroreceptors kick it back up to normal, and we don't sense any sense of faintness upon standing. But an older person whose system is not as well regulated anymore, they stand up and they feel a little dizzy. Right? It takes a moment for that pressure to come back to normal, and then they're able to move on. So this system is only for short term, not for chronic hypertension, right? But short term postural changes, standing up, sitting down. Lastly, well, we look at this little negative feedback loop. We've got this, okay? So let's start with there's a drop in your blood pressure. Reduced blood pressure. Oh, I guess this one's going the other way around. Take it back. Elevated blood pressure. What's going to happen? The arteries are going to be stretched. What's going to be activated? Baroreceptors. The baroreceptors are going to send what? Inhibitory neurons to the vagus. The vagus is going to cause the heart rate to reduce. It's also going to send inhibitions to the vasomotor centers, reduce sympathetic, and therefore vasodilate, and again, reduce the heart rate. And turn it around. Again, classic negative feedback mechanisms. There's also the chemo reflex, and we've already talked about that. So we know that it's a pH, we're measuring pH changes, which are also a reflection of oxygen and CO2 levels. Now, baroreceptors, let me go back. Baroreceptors, we know, change the blood pressure. Chemoreceptors, what's their primary job? Primary job of chemoreceptors is really to adjust your respiration. I said earlier that the chemoreceptors affect your blood pressure, and they do. But the other thing they're going to do is also more drastically affect your respiration. And we'll talk about them. We'll talk about this whole story over again when we get to the respiratory system next week. So the first thing that you're going to do is increase your respiration or decrease your respiration. And then after that, it has an effect on vasomotion. Do you agree that all three of these situations would stimulate your chemoreceptors? Hypoxemia, hypercapnia, acidosis. What are those three things? What is acidosis? Low pH. What causes low pH? High CO2, and that's what hypercapnia is. Hypercapnia, more CO2. And when there's more CO2, what is there? Less oxygen, hypoxemia. Do you agree they're all related? They're all similar. Different ways of saying largely the same thing. I'm not going to say to you they can't exist in isolation, but for the purposes of what we're thinking about right now, they're all telling me the same thing, aren't they? If you're becoming acidotic, then you have too much CO2. That is your hypercapnic. If you've got too much CO2, you would likely also have lower oxygen. You would be hypoxic. In all of those situations, your chemoreceptors are going to cause your lungs to vasoconstrict, increasing your blood pressure, increasing your lung perfusion, and increasing your gas exchange. It's also going to upregulate your heart rate, or sorry, your breathing rate. Your respiration rate's going to go up. The one neural control that I mentioned but didn't explain very much was that medullary ischemic reflex. Again, the chemoreceptors and the baroreceptors are measuring changes in blood, chemistry, and blood pressure. The medullary ischemic reflex is automatically checking the perfusion of your brain. Is your brain getting enough oxygen? The medulla is measuring its own blood supply. If there's any sort of ischemia, a lack of oxygen, a decrease in perfusion, then it's going to send a sympathetic surge and cause an increase in heart rate. Okay? Most important organ to protecting your body is your brain. So it's another safeguard to the brain. So if the brain's not getting enough oxygen, it's going to send a signal to upregulate the blood pressure to bring more oxygen to the brain. Now, what else can increase your blood pressure? We know this. I'm angry, I'm stressed, I'm aroused. All of those things will also increase blood pressure. Lastly, we get to hormonal control, and this will finish it up. We'll get through the hormonal control. Hormones can also influence blood pressure. They can influence it through vasomotive changes, changing the vasoactive effects, or through water balance. Angiotensin II is a very potent vasoconstrictor. It's a hormone. It raises your blood pressure. How does it work? It works by affecting your kidneys, telling them to promote more sodium and water retention. If you absorb more sodium, if you retain more water, then your blood volumes would go up, and so too would your blood pressure. We'll talk about angiotensin II even more when we get to the lungs and to the kidneys. Atrial natriuretic peptide, ANP, is a hormone made by the what? Atria, literally from the cells of the atria, some of the muscle cells, release this product, and they release it when the pressure is too high. So when too much blood is coming into the heart and the pressure on the atria is increasing, the heart sends out its own hormone saying, whoa, this is too much. It releases this hormone called ANP. ANP goes to the kidney and says, I want you to increase the amount of sodium excretion. As more sodium is excreted, water follows that sodium out, blood volume is reduced, and therefore blood pressure is reduced. Another hormone, you know this one, ADH. ADH promotes water retention and therefore would raise blood pressure. And finally, epinephrine and norepinephrine, which are being released during a sympathetic surge, are going to, for most vessels, cause them to vasoconstrict, that is, reduce the flow, right? But there are going to be, for example, your skeletal and cardiac muscle, where they're going to increase the flow. And how are they going to increase the flow? By opening up the vessels, vasodilate. So those are the hormones. So we've got local control, pH changes. We've got neurocontrol, baroreceptors, chemoreceptors, and ischemic reflex. And then we have hormonal control, where we're controlling all of this throughout the body. So let's drop off right there for the day. That's going to leave us about 40 slides or so to work through next time. Remember, toward the end of this chapter, it's going to be on your own, just reviewing arteries and veins. Reviewing the arteries and veins will be something you'll be doing this weekend anyway. Remember, there are 2 quizzes for you to do in preparation for next week's lab exam. They're both on Connect. One is an APR quiz. It has arteries and veins and blood cells. The other quiz is actually your lab quiz number 8, which is going to quiz you over blood pressure and cardiac output before you tackle the lab exam next week. And you'll do both of those before you sit for the lab exam. Whatever day that is next week, make sure you have both of those quizzes completed before you come in for the lab exam. Have a wonderful 4th.